consider. I'd like to request you to start your slides, please.
Thank you, madam. Very good evening to all. Thank you, the organizer, for giving me this opportunity. So, am I audible?
Yes, very much audible.
Thank you, sir. I am sharing my slide. So my topic is exercise and heart. How much is enough? So coming to the introduction, exercise and heart is a very important topic, as it has been established that exercise prevents many of the cardiovascular disease. So cardiovascular specialists require an understanding of exercise physiology, its benefit and risk, and the cardiovascular adaptation that occur with exercise training, because many of the symptoms of cardiovascular disease appear during stress of physical exertion. Patient with or without cardiovascular disease request advice on exercise from cardiovascular physiology specialists. Cardiovascular specialists are often consulted to decide whether abnormal findings in an athlete represent disease or it is due to some physiologic response to exercise training. And cardiovascular specialists must commonly evaluate symptoms in any active individual associated with exercise. So increased physical activity and fitness are clearly associated with reduction in the risk of cardiovascular disease, but the optimal intensity of or amount of exercise necessary for reduction in risks or risk factor is unknown. Studies that followed large group of individuals for many years have documented that the protective effect of physical activity for a number of non-cardiovascular chronic diseases such as non-insulin dependent diabetes mellitus, hypertension, osteoporosis, or also in colon cancer. In contrast, we see a higher rate of cardiovascular event and higher rate of death in those individuals with low level of physical activity. So coming to some specific term, physical activity, it refers to any body movement that produce substantial increase in oxygen consumption. Exercise, physical activity designed to improve health or to obtain performance benefit is considered as exercise. Exercise requiring primarily an increase in oxygen consumption and oxygen transport is referred to as aerobic exercise. Whereas exercise primarily stretching the skeletal muscle system is referred to as resistance exercise. So cardiovascular response to exercise. Physical activity increase oxygen demand, which prompts the cardiovascular system to increase cardiac output and also arteriovenous oxygen difference. 1 liter of increase in oxygen consumption produce around 5 to 6 liter in increase in cardiac output. Cardiac output is increased by augmentation of both heart rate and stroke volume. So several mechanisms is there that increase arteriovenous oxygen difference, include shunting of blood from renal and splanchnic vascular bed to exercising muscle. Then hemoconcentration from loss of plasma fluid into the extravascular space as a result of the osmotic force produced by metabolic release into the interstitial space during exertion, and increased arterial oxygen extraction by active skeletal and cardiac muscle. There is also increased myocardial oxygen demand and myocardial oxygen consumption. Myocardial oxygen consumption depends in part on heart rate and systolic blood pressure and increases with exertion, because both heart rate and systolic blood pressure increases. This increase in oxygen demand can produce ischemia in individual with flow limited coronary artery lesion. Normally, in physiologic condition, coronary artery should be dilated during exercise, but with coronary atherosclerosis, inadequate inadequate coronary vasodilation or some vasoconstriction develop because of endothelial dysfunction. The cardiovascular response to exercise has both an external work and internal work rate. This external work rate is the oxygen consumption that is required by the exercise task. It is a direct determination of cardiac output. Then the internal work rate refers to myocardial oxygen required for the exercise tasks. First one, external was required for the exercise, required by the exercise task, and internal work is required for the exercise tasks and is directly related to increase in heart rate. Coming to CV, cardiovascular adaptation to exercise. Intense and prolonged aerobic exercise produces an array of cardiovascular adaptation. Commonly, this is referred to as athlete heart. So in athlete heart, there is increased vagal tone and decreased resting sympathetic tone. So mainly in highly trained endurance athlete. This is associated due to this increased vagal tone and decreased sympathetic tone. There is resting bradycardia, marked sinus arrhythmia, and sometimes there may be first degree AV block and Mobius type 1 AV block. Sometimes there may be asymptomatic third degree AV block in during the time of sleep. There may be fourth chamber enlargement, mild increase in LV wall thickness, and small increase in aortic dimension.
Moving. Your slides are not moving.
So
yes,
in contrast to the extensive cardiac changes reported in endurance trained athlete, strength exercise training produces modest increase in LV wall thickness. So here there is some difference of endurance training and strength training, the cardiovascular response, CV adaptation. In endurance training, there is mild to moderate eccentric left ventricular hypertrophy, and also there may be RV dilatation and biatrial enlargement. There may be normal to slightly reduced resting LV ejection fraction. In contrast to strength training, there is mild concentric LVS but no RV remodeling, normal to mildly enlarged left atrial size, and normal to hyperdynamic resting LV EF. So this is a study. Here the upper limit of physiologic cardiac hypertrophy in highly trained elite athlete has been shown. They have found that among 947 national and international caliber Italian athletes, only 16 had LV wall thickness more than 12 millimeter. Another study, physiologic left ventricular cavity dilatation in elite athlete. LV end-diastolic chamber size was greater than 55 millimeter, the upper limit of normal value, in 45% of 1,300 elite Italian athletes. So in this study, an young athlete start his national competition at the age of 22 years. So during that period, his internal dimension, LV internal dimension was 55 millimeter. After 4 years, at the age of 26 years, he attained Olympic Games, and during that period, his internal dimension was 57 millimeter. And after detraining, so this is very important, after detraining, 6 years of detraining, this dimension was reduced, and also the thickness, intraventricular septal thickness also reduced. So detraining may help in clinically differentiating adaptation of exercise training to pathologic hypertrophy or pathologic dilatation, say due to some hypertrophic cardiomyopathy or other diseases. In another study, serial MO echocardiograph in a 26-year-old Olympic rower at peak training, the ventricular septal thickness had decreased from 15 to 10 millimeter after detraining. So clinical effect of exercise training is there is increased consumption, increase in cardiac stroke volume, increase in maximum exercise cardiac output. There is increase in resting parasympathetic tone and decrease in sympathetic tone, decrease in resting heart rate. So benefit of regular exercise on cardiovascular risk factor, there is increase in, as the exercise capacity increases, so there is increased exercise tolerance. Increased exercise duration and increased intensity will lead to in more calorie burn, and there is reduction in body weight. There is reduction in blood pressure, reduction in bad cholesterol, increase in good cholesterol, and also there is increase in insulin sensitivity. So effect of habitual physical activity on cardiovascular risk. Study shows more active participants have lower cardiovascular risks than sedentary counterparts. Approximately 40% reduction in risks with habitual physical activity. Even small amount of physical activity reduce the severe risks. So severe risk falls progressively with increasing physical activity until approximately 9 hours per week of moderate intensity activity, such as brisk walking. So implementation of exercise training, the type of activity, frequency, duration, intensity, and progression determine the effect of an exercise training program. Moderate intensity activity confers cardio protection to both men and women. High intensity exercise programs are often associated with poor adherence to more musculoskeletal injuries. That is why moderate the emphasis given on moderate intensity activity. So what are the cardiovascular risks of exercise? This is very important. Vigorous physical activity transiently increase the risk of sudden cardiac death to susceptible and also acute myocardial infarction to susceptible individual who have pre-existing cardiovascular disease. Exercise-related sudden cardiac death in young individual has been attributed to some inherited and congenital conditions such as hypertrophic cardiomyopathy, anomalous origin of coronary arteries. Acquired conditions like myocarditis and cardiomyopathy also may be responsible to some extent in sudden cardiac death during exercise. So recent study shows 40% of SCD in young athletes remain unexplained, maybe due to inherited channelopathy. Hypertrophic cardiomyopathy is responsible for only 6% of death. However, the risk is extremely small. For adults without existing heart disease, the risk of cardiac event or complication ranges between 1 in 4 lakhs to 8 lakhs of hours of exercise. For patient existing with existing heart disease, an event can occur in 1 in 62,000 hours. Importantly, the risk of cardiac event is significantly lower for a patient for a person who exercise 5 times in a week. Atherosclerotic cardiovascular disease causes most exercise-related acute myocardial infarction and SCD in adult. AMI during exercise in previously asymptomatic adult usually associated with acute coronary arterial plaque disruption, but fortunately, exercise-related CV event appears to be low. So, exercise and risk factor modification. There is decreased blood pressure, both systolic and diastolic, blood glucose decrease, increase good cholesterol and decrease bad cholesterol. There is also reduction of weight. So other effect of exercise in secondary prevention, it halts the progression of coronary artery disease as there is some effect on systemic inflammation. Exercise reduce the systemic inflammation, ultimately reduce the endothelial function, reduce the bad effect of endothelial wall, ultimately improve endothelial function. Now, how much is enough? So current guideline, any physical activity, usually those who are not in sedentary habit, any physical, if they start any physical activity, that may be helpful for reducing cardiovascular risk. So current guideline suggests a minimum of 150 minutes of moderate intensity activity such as brisk walking, swimming, or at least 75 minutes of strenuous activity. The moderate intensity is around 3 to 5.9 metabolic equivalent, and strenuous is more than 6 metabolic equivalent. The same physical activity levels are recommended for patients with type 2 diabetes by the US and European guideline to reduce atherosclerotic cardiovascular disease risk. improve glycemic control, and to help with weight loss. 2016 European Society of Cardiology guideline cardiovascular disease prevention in clinical practice recommended minimum of 150 minutes of moderate or at least 75 minutes of strenuous physical activity per week. ESC guideline also include recommended bouts of exercise with a preferred recommendation of 4 to 5 times per week, preferably daily or at least 10 minutes in length. So how should we begin if we want to become more physically active? First, if anyone currently have heart disease or are over 45 years of age, have or having 2 or more conventional risk factors, cardiac risk factors, should consult physician before starting any type of exercise. As guideline says, most people derive significant benefit from integrating an half an hour of moderate intensity activity. If half an hour is difficult for anyone, then try to work more activities into day by day, adopting shorter period of activity such as 10 minutes duration activity, frequent 10 minutes duration of activity. The most important thing is to get started, as any type of activity other than sedentary habit may have beneficial effect in cardiovascular health. So in conclusion, exercise or proper physical activity is an important component of cardiovascular health or cardiovascular disease management. Such activity must be individually prescribed as per the age, sex, and pre-existing cardiac condition. For being healthy, we must adopt active lifestyle. Thank you.